Okay, good evening, everyone. Today, it's my great pleasure to welcome you an SSPD webinar, which is done in collaboration with Janssen through an unrestricted support. Today, we will try to address an important critical issue in the country as well as globally, which is COVID outbreak in hematological malignancy and BMT patient. Today, the latest update from Saudi Ministry of Health showed that there are more than 1,000 confirmed cases with COVID-19 in the country, distributed in 12 cities. This is for the new cases. Unfortunately, there were 3 deaths from the disease. So I'm lucky today that we have key experts in the field of hematology and bone marrow transplant who will join us to address this issue. We have Dr. Ahmed Alhuraiji, a hematology consultant from Kuwait Cancer Center. Also, Professor Nitin Jain from MD Anderson Leukemia Division, as well as Dr. Ahmed Absi from Princess Noura National Guard Hospital in Jeddah. They will try to, the outline of today's webinar will be Dr. Absi, he will walk us through management of hematological malignancy during COVID-19 pandemic. Dr. Alhuraiji will try to address issues related to bone marrow transplantation. And then we will go with Dr. Jain over a specific disease, which is CLL. If you have any questions, please write them in the Q&A section, and I will address them to the speaker. We can do it after each talk, and then at the end we will have a Q&A where there will be an open discussion with the speakers. Without any further delay, I will forward the floor to Dr. Absi.
Thank you, Dr. Firas. I would also want to thank Janssen for this important initiative during these times. So really, I was given the task of talking about management of hematological cancers during this epidemic. I guess this would apply in general to providing cancer care in general, I think, as a general concept, which I will be concentrating on in my talk on concepts rather than details. I wouldn't dwell much into the issue of talking about coronavirus, although I'm trying to concentrate on some of the aspects that may be relevant to us. As you know, coronavirus is endemic in terms of the common cold. There are at least 4 known strains that cause common cold, which are usually mild. And then another previously 2 known strains, which is the SARS and the MERS-CoV, which causes bad coronavirus. And then the most recently is the SARS-CoV-2, which is the one that we are currently dealing with. So the SARS-CoV-2 is part of a family of beta coronaviruses, which are large RNA single-stranded viruses that are lipid enveloped. Initially, 2/3 of the initial cases were seen in a cluster at Hunan seafood whole market back in China in early November, December period. When it was sequenced, there's 80% identity to the SARS-CoV, and in 88 to 96% of the whole genome identity is with a bat coronavirus. Although bats are not suspected as the direct host, there's certainly another intermediate host, which is yet to be known. Regardless of the intermediate host right now, there is a P2P, person-to-person droplet spread that's definitely proven, and we can see it with the explosion of the exponential growth of the number of cases. The role of fecal oral is speculative, even though the virus can be detected, the virus RNA within the stool, but that role of spread is still yet to be proven. One of the issues which I thought is pretty much important, which is the issue of are we overdiagnosing or underdiagnosing? Initially, when the disease was first seen in China, and what currently most of the countries are actually doing, with some few exceptions. Most of the countries right now are testing either symptomatic patients or their contacts. There is no screening for asymptomatic non-contact patients or obviously normal individuals. Now, in China, there was one of the publication back this year, early, I think, in February or March. They detected possibility of a potential false positive rate among the asymptomatic infective individuals with close contacts to COVID-19 patients. The false positive rate that's corrected would have reached almost 50%. And it's cross-reacting with another coronaviruses. This is yet to be proven in other countries, but I think it's of importance. This is not the first time this is seen. Back in 2006, during the original SARS epidemic, an outbreak of OC43, which is a mild common cold, in one of the nursing homes in France, also had cross-reactivity with SARS, with misdiagnosis as SARS. So, but on the other hand, if you start screening asymptomatic individuals, there are also many who are turning out to be COVID-19 positive, even though they are completely asymptomatic. So we won't really know if we are underdiagnosing or overdiagnosing until the whole dust settles down. Regardless, right now, COVID-19 is, unfortunately, this is sad, but it's everywhere. It's almost in every single country across the globe. Now, how people present is they are either asymptomatic carriers, which actually constitute a major issue because they could be spreading the disease around with absolutely no symptoms. Otherwise, people can either present with mild illness, which has a very wide range, anything from diarrhea, sometimes low-grade fever, sore throat, you can name it. But then the disease can progresses with decreased frequency, so pneumonia, severe pneumonia, ARDS, sepsis, or septic shock. Now, it's important to note that the spreading of the disease really is not mostly related to the sick people spreading it in a direct sneezing or coughing. It's really contact with the surfaces, indirect contacts is what matters the most. So this has been published, I think last week, which is outlining the phases of the disease. There's an early phase, which they call stage 1. It's the early infection, where what people present with is fever, the dry cough, the diarrhea, the headache. But then it progresses to, which is the one that's more severe, that concentrates mostly in the lung with hypoxia and shortness of breath. And then the one that's actually very risky, putting people in the ICU and causing the mortality, which is the ARDS, SIRS, and the shock, which is mostly connected with a hyperinflammatory status. Now, as it stands right now, the case definition in Saudi Arabia has been changed several times, and this is the last one right now. So we do consider any person presenting with symptoms, either fever or cough or shortness of breath, and either has a contact or working in a healthcare facility or came from outside as a possible case. But we also added patients with community-acquired pneumonia as case definition, and patients in the ICU with severe ARDS as well. From China, when they published their case series, it seems that around 80% of patients do present with mild symptoms only. 14 with severe and critical is only 5%, which is fortunate. But unfortunately, those are the ones that we end up losing, or some of them at least. So cancer and COVID-19, multiple issues to keep in mind. Number one, the delay in presentation. We know this from cancer patients that they do tend to spend more time at home and do not come to the community. The second thing is that cancer patients do present a higher mortality morbidity rate. From China as well, from 2007 patients hospitalized, it seems that patients with previous history of cancer or active cancer has a 39% rate of severe event, either ICU admission, intubation, or death versus 8% to others. 20% of 355 Italian deaths were patients with active cancers. And finally, the other relationship between, or potential relationship between cancer and COVID-19 is the issue of blood donation and blood products. What has been termed RNAemia, which is the presence of viral RNA in the blood, has actually been found in patients with COVID-19 as well as in other SARS viruses. But the presence of the infectious virus not established. So the presence of the RNA doesn't necessarily mean automatic infection, but it is an issue for asymptomatic donors. Here is the issue. So I will just stop here and really look at the issue of blood banks and relationship to COVID-19 infections. First of all, there's an issue of demand and supply. With people, like right now in Saudi Arabia, we have partial curfew. So we do have much less donors. And this is not to mention donors who are sick to start with. So donor screening, we still yet to implement that we don't really routinely screen donors, asymptomatic donors for COVID-19. We may end up doing that if the disease has been proven to transmit. But I think the most pushing issues is how do we keep with the demand? So many centers do have to review their indication managements, non-surgical indications, things like stem cell transplantation or chemotherapy. Planned semi-urgent can be deferred. Severe bone marrow failure syndromes, for instance, utilizing a minimal transfusion model. Thalassemias, but considering lower threshold. Sickle cell disease crisis affecting the organs is definitely something that we cannot skip. Sickle cell patients less than 16 with past history of CBA, but as they get older, this is something also we can skip. The second is requirements management. And then the fourth is threshold management. So when do we actually transfuse those patients? So threshold management, for instance, we can adopt a lower transfusion cut point of 7 in hemoglobin rather than 8, and which has been shown to be safe. Platelets as well, lowering the prophylactic transfusion to 5, for instance, rather than 10 in patients who are not sick or not allogeneic bone marrow transplantation. Also eliminating prophylactic transfusion in certain indications and only transfuse when the patients are actually symptomatic. And finally, using or utilizing tranexamic acid to decrease the bleeding tendency in thrombocytopenic patients. So our first and utmost important point here is how to protect our patients when there's so much uncertainty around. First of all, which has been definitely emphasized, is social distancing, definitely, for the patients and for the healthcare providers. Rescheduling non-essential appointments, and I think many centers already started utilizing that. Rescheduling has to be accompanied with provider-patient communication. Without appropriate communications, patients will be left with so much uncertainty and fear. So triaging and assessment strategy, hotline phone accessibility for patients is very important. The last thing for a patient wants is for his appointment to be delayed with no way to get back to the hospital. And limiting ED visits, applying neutropenic fever risk stratification. So patients who we know have lower risk of neutropenic fever should not automatically be sent to emergency departments. And atypical presentations, which is very important to keep in mind. So lack of fever in those patients could be an important aspect. Their presentation could be simply sore throat and diarrhea without fever. Information. We need to address the goals of care for our patients with COVID-19 and without COVID-19. We do say that all the time, but now it's of more importance. So patients who wish or can eligible to be discussed as no-code patients, I think this is the right time to do it. And need to address the anxiety levels of our cancer patients and their caregiver. The second aspect is taking care of the healthcare service provider themselves. This is a quote from an Italian doctor about describing their situation as physicians, which you can read. And definitely nobody wants to reach to that point. So more stringent application of social distancing and hygiene recommendations for healthcare provider is of utmost importance. Workload distribution rotation is another thing to do. In our institution, for instance, right now, we're trying to apply a model of 1 week on, 1 week off for oncology care providers, physician-wise. And work breaks and counseling is also important. I'm sure every institution have a pathway like that already of how to deal with a healthcare worker that has an exposure of a confirmed or suspected case. And if an institution doesn't have, they should, because that's of importance. I think this is the most important slide for me today, is an experience that has been applied from Italy, and I did some modifications on it to suggest each institution, they should have a similar model. So this is how they deal with patient with cancer. And they broken down into 3 groups: patients off treatment, patients receiving potentially curative therapy, and patients with metastatic disease. So patients off treatment should be dealt with like any other people in the community. And the strategies should be mainly prevention with the outlined measures. Patients with on curative, potentially curative therapy, the measures will include things like, additional measures will include things like limiting close contacts, and that's very important. Cancer team should use always PPE when dealing with those patients, because we don't know who of the healthcare provider is actually an asymptomatic carrier. Close monitoring for potential toxicity and COVID-19 symptoms is very important. And what they called COVID-19 clinical pathway, COVID-19, free clinical pathway, which is how to develop a clinical pathway within the hospital where those patients are exposed to the limited risk possible of COVID-19. They also identified something called hub centers. Certainly not every oncology center can provide such a care, but maybe naming certain centers in the country which are able to implement stringent criteria within the hospital to develop or provide something called COVID-19 free clinical pathway is probably something that makes sense, especially in providing high risk or high acuity oncology care like leukemia induction. Finally, treatment implications, things, those are all open-ended questions, and you will find many recommendations will gradually come up in the literature that are addressing many of these things. So, things like immune checkpoint inhibitors, where they are known to cause, for instance, pneumonitis. If we are giving those for an indication that's soft indication, maybe this is something that need to be rethought about. Other drugs that are caused to cause pneumonitis, maybe also we need to think when we are giving them, and if they could be replaced like bleomycin or brentuximab vedotin. The other point or the other approach is using less intensive regimens associated with neutropenic fever. So, using, for instance, BR versus FCR in low-grade lymphomas or CLL would be another thing. You probably have seen this publication, which came up yesterday from the NCRI AML working group. I wouldn't definitely go into details, but I'm just summarizing how you will gradually see such recommendations coming for all diseases. And the recommendations will all come into one of 3 categories: using less intensive therapy whenever possible. And as an example here is high-dose RSE limiting to 1.5 grams. Reducing cycles whenever possible. So for instance, reducing the cycle of ATO-ATRA consolidation for a molecularly negative consolidation, and more in cooperation of novel agents, which are less known associated with neutropenia. Finally, this is the last slide, which is also a publication came out a couple of days ago, where maybe those patients who are developing this hyperinflammatory status are behaving like a secondary HLH syndrome. There are some similarities between 2 situations: the increased ferritin, the increased interleukin-2 and interleukin-7, and maybe the efficacy of interleukin-1 blocking agents and interleukin-6, like to see lisozumab. And that's something to keep eye on. So I will stop here and give the podium back to you, Dr. Firas.
Thank you, Dr. Ahmed. It was an excellent talk. So we have questions from Dr. 2 questions from Dr. Hani Hashimi. So So I'll start with the simpler, with the shorter one. So he's asking specifically about tranexamic acid, suggestions in what, when, what doses, for how long. So he's asking about transfusion management during a COVID outbreak and the utilization of tranexamic acid. Dr. Absi.
Yes, so I guess he is referring to the study of tranexamic acid decreasing the rate of bleeding in patients who are thrombocytopenic. And definitely that's something to be utilized in our patients, but keeping in mind utilizing it for patients who are with low risk rather than high risk. So whenever a patient having, allogeneic bone marrow transplant is probably not something that you want to use tranexamic, at least my point would be, and probably you'd be more experienced in this than me, but patients who have low thrombocytopenia in the setting of consolidation, for instance, for AML, maybe using or utilizing tranexamic acid for those patients would make sense. I mean, as you all know, the dose is 10 milligram per kilogram or 25 milligram per kilogram orally every 8 hours. That has been utilized in the study, but maybe each center may have a different recommendation.
Thank you, Dr. Ahmed. Another question from Dr. Hani is asking about manpower management during such a crisis. Is there any specific recommendation, either local, regional, international, or WHO, in how to maximize the utilization of the manpower during such a time without jeopardizing the health of the staffs?
Yeah, so that's important, and that's actually very important. Now, some hospitals are already doing something called cross-specialty training or crash courses on cross-specialty training, because the last thing that you want to happen is having one of the staff turning out to be positive, and then you have to isolate all his contacts, which includes the whole leukemia service probably. And then you end up with a situation where you don't have anybody to cover the inpatient leukemia service. So at least what we have utilized in our hospital is to work on 1 week basis. So 1 week on, 1 week off. Although if you probably want to do it per the recommendations, should be 2 weeks on, 2 weeks off, because that would at least maximize the 14 days non-contact. So, but definitely such a model should be implemented, because if everybody coming to work each day and then one of the oncology docs turns out to be positive, even 1 day you cannot quarantine those people. Who's going to cover the inpatient leukemia service?
Thank you again, Dr. Ahmed. Another question from Dr. Saud Abu Hirbish. He's asking, many blood banks now are calling for a support due to the shortage of blood products. Any strategies in how to tackle this problem in regards to donor management? How to maximize donor management?
Short of encouraging our staff themselves to donate, it's very difficult. Unfortunately, it's a major issue right now. As you all know, many hospitals right now are preventing even visitors. And most of our donation used to come from visitors. Obviously, mobilizing the mobile units down to the community outside the hospital would make sense. But the problem is, even in such scenario, where are you going to take this mobile unit to? I think it's really working. It's going to be a model where you're combining both contacts with your patient and their families and offering them accessibility to a mobile unit somewhere. That would be the best scenario. But unfortunately, there's no easy answer there. Definitely no easy answer. And definitely applying also or implementing the new healthcare technology or internet applications. So there's this application for blood donors that took some publicity recently, and probably this is the time to utilize it.
Thank you, Dr. Absi. I mean, due to the sake of the time, we will go to the next speaker, and we will try to go back to the unanswered questions at the end in the Q&A session. So the floor now will be for Dr. Ahmed Alhuraiji from Kuwait Cancer Center to address management of bone marrow transplant during COVID outbreak. Dr. Ahmed.
You see my slides? Hello?
Yes, we see your slides.
Yeah, we do.
Okay, thank you so much, Dr. Firas, for this kind of invitation. Thanks to Jensen for this great initiative in this time of COVID-19 pandemic. And again, thanks to Dr. Absi for such wonderful presentation and just easing the road for me for the today talk, which will be a practical approach to BMT patients during the COVID-19 pandemic. I'll be my talk based on the recommendation of the American Society of the Transplantation, as well as the EBMT and British Society of BMT, although there is no solid evidence based for this recommendation, but definitely that will help you guide your treatment for your patients for better care. As the Chief Medical Officer of the American Cancer Society said, that we are headed for a time when there will be significant disruptions in the care of patients with cancer. And definitely that will change the way we're treating our patients in the next few months enormously. As mentioned by Dr. Absi, that based on this small study, although it gives us a sign that patients with cancer might suffer more severe events when they get COVID-19 than non-cancer patients. And with that, we have to be very cautious and very careful, and we have to balance the scale of not under-treating people with cancer, leading to more mortality, and not at the same time treating vulnerable patients and they can get COVID-19 and then will run into some troubles. So in Kuwait has taken a great initiative as well and enormous efforts to stop and prevent the COVID-19 pandemic. They put a 24/7 hotline 151, and they have a website that give us the stats on a daily basis. As of today, the number of cases in Kuwait is around 208 patients with no mortality, and almost 50 patients has recovered from the COVID-19. And also the country has locked down, and all returning travelers, they were put either in institutional quarantine or home quarantine based on the risk of the area that they're coming from, until more recently when they locked down the country, and then all the travelers who are coming back to Kuwait, they should be put in institutional quarantine. Not only that, many algorithms have been published and distributed among healthcare providers. And this is one of them, this how to triage patients with COVID-19 when they come to the ER, using the history and examination, as well as the rapid COVID-19 antibody testing, as well as the new PCR testing. And all patients who are tested positive for COVID-19, they will be transferred to one designated hospital, which is Jaber Hospital. So as far as for my talk for the transplant unit, they should have the prevention strategies as per the WHO guidelines. They also have to review and set up management policies and procedure. This should be aligned with the local and national authorities' guidelines. And they have to screen patients for upper respiratory tract infection during the transplant pathway. And these are the WHO recommendations. I think most of you have been across this guidelines. And for the recipients, the approach will be as follows. If the recipient has COVID-19 positive, then the transplant has to be deferred for at least 3 months. unless the disease, and unfortunately, this is not always possible to defer the transplant for 3 months. So because of the underlying disease, sometimes we have to go for transplant, but given at least a minimum of 14 days until the patient is asymptomatic and having a negative PCR for COVID-19. Whereas recipients who had a contact with a confirmed COVID-19 cases, the transplant has to be deferred for at least 14 days and more preferably for 21 days. And the patients has to be monitored closely. And before transplant, we have to have 2 consecutive negative PCR for COVID-19, 1 week apart. For patients who are coming from a high-risk area, the American Society of Transplantation, they suggested to screen them at initial evaluation and 2 days prior to the conditioning. Whereas the EBMT have done also the same, plus the self-isolation at home for 14 days. All the societies have recommended to refrain all recipient from non-essential travel and to practice good hand hygiene and avoid crowded places as well as large group gathering for at least 28 days. The British Society of BMT also suggested to screen even asymptomatic patients who are not coming from a high-risk area or who did not have a contact with COVID-19 positive cases, and to defer any non-urgent transplants, such as those we're doing for like myeloproliferative neoplasm, for example. What about the autologous stem cell transplant? They suggested to minimize the priming with chemotherapy as much as possible and to use the GCSF. Any patients who with underlying benign condition, the transplant has to be deferred until the peak of COVID-19 passes. Whereas patients with a low-risk malignant disease, the transplant has to be deferred for 3 months. What about donors? The donors, any donor who are tested positive for COVID-19 should be excluded from donation. Unless the transplant is urgent, then the deferral has to be for 28 days, along with resolution of the symptoms and negative SARS-CoV-2 by PCR. If they have a contact with COVID-19 positive cases, the donation has to be deferred for at least 28 days until they are asymptomatic and have a negative SARS-CoV-2 by PCR. What about if they're coming from a high-risk area? The donors have to be excluded again for at least 28 days. All societies have also recommended that the donors should practice good hand hygiene and avoid crowded area and large group gathering for at least 28 days prior to the collection. The Anthony Nolan, which is a non-profit organization for bone marrow transplant, they can facilitate backup donors in UK if the transport of the first donor cells are problematic. We built an algorithm for our BMT program at Kuwait Cancer Center, starting from, so for the recipient, we ask the first question whether the transplant is urgent or not. If it's not urgent, then the deferral is recommended for at least 3 months. If the transplant is urgent, then is the recipient COVID-19 positive? If yes, then the transplant should be deferred for at least 21 days until the patient is asymptomatic and have negative COVID-19 by PCR. What about if he has no COVID-19? So the second question will be, does he have contact with COVID-19 positive cases? If yes, again, the transplant should be deferred for at least 14 days with 2 negative COVID-19 by PCR, and we have to monitor the patients closely. If he has no contact with COVID-19 cases, then the next question will be, is he returning from a high-risk area? If yes, then the deferral should be for at least 14 days. If he has not returned from high-risk area, then we can proceed with transplantation. We usually don't do routine screening for COVID-19 in patients who had no one of these risk factors, and we don't do transplant for benign condition nowadays. We are not also doing for a low-risk disease such as MPN, And we follow the WHO on how to protect yourself and the others on our patients. And we prefer that for home isolation for 14 days for all our donors and recipients before transplantation. Another algorithm was also designed for donors. So is the donation is urgent? If no, then we defer the donation for at least 3 months. The donation is urgent, then is the donor COVID-19 positive? If yes, then we defer the donation for 28 days until the donor is asymptomatic with a negative COVID-19 by PCR. If he is not COVID-19 positive, again, does he have a contact with the COVID-19 positive cases? Then, if yes, we defer the donation for 28 days with a negative COVID-19 by PCR, and we have to monitor the donor closely. What about if he has no contact, then again, returning from a high-risk area? If yes, then we defer the donation for 28 days until we make sure that the COVID-19 by PCR is negative. And last question, if he's not returning from a high-risk area, then we can proceed with donation. Again, no routine screening for COVID-19 in asymptomatic low-risk donors. And we don't do donation nowadays for benign conditions or low-risk malignant disease. We also follow the WHO recommendations. We ask our donors to isolate themselves at home for 14 days prior to the transplantation. What about the matched unrelated programs? The National Marrow Donor Program secured a travel ban waiver signed by the CDC to allow the European BMT couriers entering the US on 16th of March, a few days ago. In the post-transplant period, while the patient is in the inpatient, we minimize the number of family members. We educate all family members on hand hygiene, and we ask the patient should be managed in a strict protective isolation. We assess the risk of the need for any investigations like ultrasound, going outside the room, or procedures to minimize the exposure to the outside. What about after this discharge? There is a recent publication in JAMA that said that cancer patients, they are at a higher risk for getting COVID-19. And the post-BMT recipient, definitely they are at a greater risk for COVID-19. And so we have to reinforce the need for self-isolation, minimize the clinic visits, set up a telephone follow-up clinics as much as possible, and to do blood tests away from crowded area in the hospital. So with that, I would like to thank you and happy to answer any questions. Thank you.
Thank you, Dr. Ahmed, for an excellent talk. So we have a, so just for the sake of time, we'll take 1 or 2 questions. So the first question I have is regarding timing of bone marrow transplant for severe aplastic anemia. When shall you time for transplant, Dr. Ahmed? Dr. Ahmed, you are in the mute mode.
So the European CDC, along with most of the society, have recommended to postpone and defer transplant for at least 3 months. However, this is not always possible. So I would recommend to take a call on like an MDT meeting with the risk and benefit ratio, along with the patient's as well discussion to go ahead for transplant or not.
Okay, so the second question is from Dr. Saud Abu Harbish. He's asking if you can elaborate more in urgent indication versus non-urgent BMT indications.
Yeah, I think as I said earlier, there is no clear definition of what's urgent and what's non-urgent. However, we can take a call based on the underlying disease, such as patients with acute leukemia, high-risk disease. I think these people needs to go for transplant as soon as possible. But the other conditions like myeloma, you can just defer the transplant whenever possible, maybe in progression or just at a later time point. So to be honest, there is no clear definition on what's urgent and what's not urgent. So it's basically a discussion in the MDT as well as with the patient himself.
Thank you, Dr. Ahmed. For the sake of time, we will move to the next speaker. We will go back to all the unanswered questions in the Q&A session. So I will hand the floor to Professor Nitin Jain from MD Anderson Leukemia Division to address specific challenges for CLL patient during COVID outbreak. Dr. Jain.
Hello. Let me try to share my screen. I think Ahmed, yours. Let's see. Can you guys see my screen?
Yes, thank you.
Okay. So,
Dr. Jain, if you can put
yeah.
it in, maximize the slides or put it in the, yes.
You see it now?
Yes.
Is it good? Okay. So thank you, everyone, and thank you for the two wonderful talks, and thank you, Jansen, for organizing this. So the topic given to me was specifically to talk about CLL management during COVID-19. So much has already been discussed about COVID-19, the management, the transplant management, the leukemia management. So my talk is going to be slightly just more focused on CLL. So this is was kind of already alluded to. This is one of the websites which updates the data, I think, in real time. As of this morning, all over the world, close to 500,000 people have been infected with coronavirus COVID-19, and 22,000 deaths all over the world with this disease. And as you can see, the snapshot, the figure, the world figure in the middle of the figure here, pretty much it's affected all over the world, especially in China, Europe, and now in the United States. So I think at the get-go, I would say that, all the discussion so far, I think, there's very limited data to go by, and all these are kind of expert opinions about what should be done. Specifically for CLL, there is no CLL specific data available at this time. I think in due course, maybe in the next 1 to 2 months, we may start seeing some of that, but not yet. We would assume that given the immunosuppression patients have with CLL, that there would be at high risk of developing severe complications if they were to get COVID infection. And as was already alluded to, I think the key here would be the social distancing, and I would encourage to follow your state or country specific guidelines in terms of what needs to be done, depending on the risk in that particular area. So in the next few slides, I thought I will kind of look at individual CLL patient in a way to see what you may want to consider. So if you have a patient with CLL who's not on active therapy, so these would be early stage CLL patients on clinical observation. They haven't had any therapy, you're just watching them. Or patients who may have received therapy in the past, such as FCR or BR, and now at this present time, they're not on active therapy. Now, many of these patients, you may generally be seeing them on a 3 to 6 months basis in your clinic. But I think in this specific case, you really want to avoid all routine clinic and follow-up visits. So I think these are specifically the patients where most of them are pretty stable, and these could be managed over the phone call or telemedicine, and you can avoid them, tell them not to come to the clinic area or the hospitals for routine CBC. So I think that's important, and that's what we have been doing at MD Anderson for our clinic patients. The second group of patients might be who are about to start therapy. For example, a patient with CLL who was being observed for a while and now they're progressing and you're discussing starting treatment for CLL. And this could be first line of therapy or maybe a relapsed line of therapy. I think in this situation, I think you could consider deferring the therapy if possible for at least 3 months, hoping that in 3 months things may be a bit better. But here the decision is really individualistic. I would say that most times for patients with CLL, you're able to delay things because there is not an immediate need at that very day to start therapy. But certainly if a patient has, a significant anemia, rising white count lymph nodes, you may not be able to wait 3 months. And in that case, you will have to start therapy. So I think if the therapy must be initiated, one could argue to maybe favor more non-chemotherapy based regimens, just with the hope that there will be less myelosuppression, less neutropenia, less GI toxicity, and maybe that way, if the patient were to get exposed to COVID-19 or get COVID-19 it's himself or herself, they may be able to better tolerate that infection. Patients who are on active therapy, so for example, if they are getting chemoimmunotherapy such as FCR or BR, or they're getting target therapy such as ibrutinib or venetoclax-based regimen, again, these are, I think, a tough situation. So what to do? At least in our group, we are not stopping therapy or reducing therapy for these patients at this time. But what we are trying to do, at least, is to try to limit their exposure. So again, the same argument before, try to limit their hospital and clinic visits. If they are receiving ibrutinib, they are obviously getting the therapy at home, they're taking the pills at home. You can call them, or the nurses can call them, make sure they're okay. And rather than having the routine follow-up visits, which they may be coming for toxicity management. Again, these recommendations may change, depending on if there's a lot of COVID-19 in the area and patients are worried about it. But at least for now, we are not curtailing treatment or shortening the treatment regimen for our patients or stopping the therapy based on the risk of COVID-19. Now, if a patient were to become COVID-19 positive, has CLL, and then they have a documented PCR positive COVID-19 disease, I personally think that for most patients, we should be able to hold therapy for CLL temporarily as we're kind of managing the COVID-19 disease, with whatever your institutional guidelines is. Now, sometimes patients who are on a BTK inhibitors, ibrutinib, they can have some flare of the disease if you were to stop therapy. But I think for most patients, they should be able to, in my opinion, hold therapy temporarily as we are kind of managing that COVID-19 disease in that particular patient. And as I said, for the management of COVID-19 disease, that's not obviously the part of this discussion or webinar, but you should follow the institutional guidelines of how to manage that patient. Now, I write something about here IVIG. I think IVIG is not going to help the COVID-19 per se, but if the IVIG is low, you may consider it, hoping to prevent any secondary infection, which these patients are also likely prone to get. And my last slide, which is actually just this morning, I found this case report actually in a CLL patient, probably the first case report of a CLL patient with COVID-19. The patient actually had a good outcome. Patient was a young guy, 39-year-old, with prior therapy of R-CHOP and then with chlorambucil. And kind of you can see he had a CT scan here. The first top two figures are when he had the COVID-19 disease. So you can see obviously the pulmonary infiltrates. And the bottom two figures are the same cuts at a later time point when he's doing better and he's now discharged and doing well. So certainly I think a favorable positive outcome in this particular patient, but that's something I think we have to see as more patients get diagnosed with CLL or other leukemias for that matter with COVID-19. So thank you for your time, and we'll be taking questions in the panel discussion now. Thank you.
Thank you, Prof. Jain. I'll go some of the questions that we have received. So there is a question regarding how would you manage CLL patients who are on a ibrutinib during COVID outbreak? Any specific modifications?
Yeah, so what we are doing, again, this is an evolving recommendation. Right now, again, we are not changing or holding therapy proactively for patients who may get COVID-19 disease. So I think the prevention is the key here. And maybe CLL patients should take extra precautions just because the cancer patients in general are at a higher risk of complications. So extra precautions in terms of social distancing. If they are in a work environment where there are multiple people, maybe try to get a leave of absence so that they can stay at home and kind of away from the crowds. But I think if they're on ibrutinib, I personally don't think, at least with the data we know right now, that we should be changing the therapy proactively in that sense. But if a patient were to get a COVID-19, I think then that kind of maybe consider holding the therapy in the short while they're being managed for their COVID-19 disease. But again, that could also be, one could argue, to maybe keep doing it because some patients can get some flare of their disease when you stop it. But in my experience, most times, a brief hold of ibrutinib can be done safely in specific situations.
So there is a specific question, Dr. Jain. Do you have any CLL patient who got infected with COVID-19?
So we actually at MD Anderson, we don't have any leukemia patient right now who's infected with COVID-19. But however, we are aware of a patient, our clinic patient, not my clinic patient, one of my colleagues' clinic patient elsewhere in the United States, who was getting treatment with us and has COVID-19 disease. But that was just actually this morning we came to know about that. So again, we don't. So it's like like I said, the recommendations here are based on what we think, but a lot of these things may evolve as we and other centers in the US and elsewhere start having more patients with COVID-19, and then we'll have to see how they're doing. But yeah, right now I don't have a patient in my practice yet.
Okay. Two more questions. And any special prophylaxis or dose modification for CLL patient?
Again, nothing specific for the prophylaxis. I mean, I guess if you're saying prophylaxis for coronavirus, I mean, COVID-19, there are studies being done, not for CLL patients, but for healthcare providers in general with hydroxychloroquine. I saw some study at NIH, a very large study looking at hydroxychloroquine as prophylaxis for COVID-19 exposed healthcare providers. But that's a very specific scenario, that obviously I won't recommend you start taking hydroxychloroquine right now, CLL patients. But so I think nothing specific in terms of infectious disease recommendation. I would say I would see whatever most of the time we have prophylaxis for HSV prophylaxis with acyclovir or valacyclovir. That's what we typically do. Some centers also do PJP prophylaxis. We generally don't do it, but some centers do that. So I would just follow what your oncologist or what you usually do for your patients, nothing more at this time. That would be my opinion.
Okay, so this will be, the last before switching to other speakers, and we might go back to you if needed. So there's a question regarding the starting treatment for a newly diagnosed CLL. Any modification for the time being?
So it was a bit difficult to hear from me, but I think you said starting indications for patients with CLL, treatment indications?
Yeah, treatment indication. Would there be any modification during COVID-19 outbreak?
Right, so I think you can a bit more lax in terms of when you initiate treatment. So last week I had a few patients who were thinking of starting a treatment on a clinical trial for a frontline therapy. But if most of the time, still you can wait for some more time. There's not an immediate need. Yes, the platelets have come down to 90,000 or 80,000. The lymph nodes are growing a bit, but you can, most of the time, these things have been slow growing and you can defer the treatment for 6 weeks or 8 weeks or 3 months. So So if that's a possibility, I would recommend that in doing that so that, and it's not just getting an infection, it's also, I think it's not just the treatment, but I think any treatment you initiate that will require some back and forth to the medical center and extra exposure to the patient in that sense. So, but certainly there will be patients where you're not able to wait that long, and those patients have to be initiated, and you know, just kind of do your best. In that scenario, also, if possible, try to see if you can limit their visits to the hospital and try to do more by phone calls or telemedicine.
Thank you, Prof. Jain. So we'll be switching to Dr. Absi for questions in the hematological malignancy. So Dr. Absi, there's a question. A patient with aggressive lymphoma who got treated for COVID-19. When shall you restart the treatment?
Okay, so again, fortunately for us, we did not face this dilemma yet, and I hope nobody would. In my view, it depends on which is the clinical scenario or what category the patient falls into. So the diagram that I showed you, which is the phases of the disease, phase 1, 2, or 3. So if the patient is within phase 1, I think the minute we document negativity, so he is presumably developed immunity to the COVID-19, then that patient could definitely restart. But the patients who is in phase 2 or phase 3, I think restarting therapy here would, plus elimination of the virus, will require normalization of his general status. So if the patient is on oxygen, he should be off oxygen. If he has, definitely, if he's in the ICU, he has to be back in a normal flow, off oxygen, back to his baseline or as close to baseline as possible, like any other neutropenic patient who develops ARDS. We would not restart his therapy until the patient is the closest possible to normal.
Thank you, Dr. Absi. So there is another question. So this question from Dr. Hani. So with the data suggesting a male gender as a risk factor, poor outcome, any recommendation to dose reduce some protocols based on male genders? Dr. Absi?
Yeah, I'm not sure. That's a tough one. Yes, males has been associated with in COVID-19 epidemic with higher risk of severe complications, but we don't know that. Why is that happening to start with? Are they because there are more smokers, they have more chronic disease? We still need to see the publications and to stratify for all other risk factors here. So I would find it difficult to make any recommendations right now based on gender, only based on this issue. But definitely, I think the concept itself, which is stratifying the patient between a curative treatment intent versus palliative treatment intent, would be of utmost importance here. So all patients who are being treated palliatively, I think using a less intense approach would make sense, regardless of their gender, obviously.
Okay, another question, Dr. Absi, is 54 years old male, a newly diagnosed LGL, neutropenic. Would you start him in methotrexate next week?
Well, such a patient is already at risk because given his neutropenia. And I mean, I would love to hear from you guys as well, other panel members. But for me, I would see methotrexate as a very reasonable option for this patient. It's associated with probably the least risk of infection compared to other options. And you're hoping to correct his neutropenia. The patient is already neutropenic. So, but also remember that those patients have benign neutropenia. So it depends. The history of the patient here matters. If he is somebody who's running recurrent neutropenic fevers versus somebody who has been stable. I have an LGL patient who has been living years right now with neutropenia. So if the patient is not running recurrent infections, maybe deferring therapy a while until things become clearer. Is this first line or subsequent lines? I think all these are taken into account.
Okay, thank you, Dr. Absi. I will switch to the BMT session with Dr. Alhuraiji. We have some questions here we haven't answered. So Dr. Alhuraiji, so the first question is, do you do a cryopreservation now? Before collecting the donor in advance, cryopreserve it, and then to reinfuse before the conditioning.
So some society has recommended that you can do this, provided that the patient or the donor is asymptomatic and has no travel history and has tested negative for COVID-19. Then you can just cryopreserve and just wait for a while until the transplant is needed. Then you can go ahead with transplant.
Okay, thank you, Doctor. So, Dr. Alhuraiji, another question is, would you support performing transplant as an outpatient instead of inpatient at such time?
To be honest, nowadays, because of it depends on the prevalence and the epidemiology of the area itself. So if you are in an endemic area, then probably it's better to do it as in-house to make sure that there is an institutional isolation and the patient has no contact with other people, then to minimize the risk of getting COVID-19. So I would recommend doing it nowadays as inpatient, yes.
Okay, another question, Dr. Alhuraiji, from Dr. Khalil Farsi. Excellent talk. For relapse, refractory Hodgkin or non-Hodgkin, would you consider them as an urgent cases for transplant?
I think they are considered, but I think we have to just approach them the same way, that if they are the area, I know Oman and the Kuwait, the situation is a way better than other areas. So if you have a good capacity of beds and the patient is asymptomatic again and has negative COVID-19 by PCR, I think the relapsed Hodgkin's lymphoma and non-Hodgkin's lymphoma, they would fare better if you just provide them an autologous stem cell transplant, much more than if they left alone without any treatment or any transplant.
Okay, another question, Dr. Alhuraiji, is for neutropenic patients who are either post chemo or conditioning BMT and they are neutropenic, would you prefer to keep them inpatient or at home during neutropenia period?
It depends on, actually it's not, it's a tough one. It's very difficult to answer, but I think it depends on how severe is the neutropenia. If it's severe and checking their immunoglobulins level, if they're in immunosuppression or not, if they have active GVHD or not. I think there are different factors that will play a role here, along with the COVID-19 status in the country. So one would weigh the risk and benefit and take a call. If the benefit would outweigh the risk of keeping the patient in hospital, then I would go with an inpatient service approach.
Thank you, Dr. Alhuraiji. I'll switch to Dr. Prof. Jain. I have many questions about CLL. So the first question is, do you think it's safe to use monoclonal bodies for CLL patient these days?
Well, so rituximab, I guess they're talking about, or obinutuzumab. So, again, I think it's we have not changed our practice in that regard, I would say, that yet. I think if you are, for example, if you're right now in New York, where there's a lot of patients and exposure, I think maybe a different argument than maybe where I am right now in Houston, where there are cases, but it's not an onslaught of cases right now. So I think for now, I think we're still pursuing the standard treatment in a way. If you have to use monoclonal antibodies such as rituximab or obinutuzumab, They are getting those right now at our center. But again, whether you should stop doing that, I really don't know the answer to that unless we know more, whether the patients who have received like clinical data to say that patients who have had rituximab or obinutuzumab, they're at a higher risk of getting some infections or complications or severe complications from COVID. We just don't know that.
Thank you. There was a question: if a CLL patient got infected with COVID, will you hold the treatment? I think you already answered that. So you will hold the treatment. And there is a comment actually from Dr. Saeed Ahmed. He's saying when we are talking about delays or rescheduling treatment, we are saying 2 to 6 weeks. However, if you look at Italy, for examples, I mean, the situation stayed much longer, and this leaves us not as optimistic as others actually. So, what any comment, Dr. Jain?
Well, so we are at our center. We are, patients who we're trying to reschedule. We're trying to tell them to come back in like 3-month window from now. So sometime in June, we're hoping. So again, this is an evolving kind of a target, but we're trying to see if patients' therapies or reschedule their clinic visits can be done 3 months down the line. So that's what we are planning for. I do think that in 4 to 6 weeks, we still will be dealing with this situation, but maybe hopefully 3 months down the line, we'll be in a better position.
If I may add also, Dr. Firas here, just one comment. Yes, true. We don't expect to be done with this in 4 to 6 weeks, but we should use these 4 to 6 weeks to be better prepared with clear pathways on how to deal with situations like this. I think every center right now should go back, do their homework, study the patient population they have, study who are they treating, study the protocols they are implementing, and have an answer for one of each different situations. There's no universal answer for all. But I would prefer to deal with a patient, God forbid, who has COVID-19, who's neutropenic 4 weeks from now, rather than dealing with him tomorrow, because we would be better prepared.
Thank you, Dr. Absi. Dr. Jain, another question regarding a CLL patient who is in venetoclax plus obinutuzumab. Will you obinutuzumab for the time being and continue venetoclax alone?
I guess the question is if you will hold obinutuzumab for the time being and keep venetoclax alone.
Yes.
So again, I think those are obviously the reason of holding obinutuzumab will be that you're worried about more risk of neutropenia with the combination, which could be up to 50 to 60%, as opposed to maybe 20 to 30% with venetoclax alone. I think these are individual decisions. I think if a patient has very high risk feature disease, and I worry that single agent venetoclax, using single agent venetoclax as opposed to the combination, you are going to have likely less risk of MRD negativity. Yes, there is a high risk of neutropenia, but in the long run, maybe that's okay, and maybe this patient needs to be treated with the 2 drugs together because he has a high risk disease, and that's what you're trying to achieve, MRD negativity and maybe a long-term disease-free survival for that patient. I think so. So I think there is no right and wrong. Maybe also at the same time, if you have a patient who has received maybe 3 doses of obinutuzumab, you check a peripheral blood MRD, they're already negative. Maybe in that particular situation, maybe you say, hey, maybe I can hold the additional obinutuzumab doses here. But again, these are not data-proven kind of answers. I think these are individual decisions which you have to make. So that's what I may think about when I'm thinking about a patient, whether to give additional doses or not. That being said, again, at our center, we have not yet changed our practice. And I think every institution may be a bit different depending on the patient population and the risk prevalent in their community for COVID-19.
Thank you, Prof. Jain. Another question from Dr. Saud Belila, 53 years old, 53 years old, we don't know the gender, CLL, trisomy 12, started on FCR protocol. He received 1 cycle only. So for the second cycle, would you recommend switching him to ibrutinib, rituximab, or bendamustine, rituximab, or venetoclax?
So again, a tough question. I mean, I think in general, the field, I mean, again, that's a discussion maybe outside of this webinar. I mean, the field of CLL is moving more towards targeted therapies and less towards chemotherapy and less chemotherapy. I think if you have made a commitment to this patient of using FCR, I think maybe continue with that argument. Maybe if they did well with the first cycle, if they developed syncytial neutropenia with cycle 1, had some complications, then maybe not the best choice moving forward. But if they tolerated it fine, I think you started it for a reason, and I would at least maybe proceed with that plan. But as I said, a different opinion could be taken here to switch to targeted therapies, and at least in our center, most patients are getting targeted therapies these days for CLL and not chemoimmunotherapy.
Thank you. Another question about azithromycin and ibrutinib.
Use of azithromycin with ibrutinib? I don't think, and I'm not 100% sure, but I don't think there's any drug-drug interaction with ibrutinib and azithromycin. So we have, I mean, again, azithromycin, the question will be for the COVID-19 treatment, maybe as part of, as what is being, the new regimen to look at is hydroxychloroquine plus azithromycin. So I don't think there's any drug-drug interaction, so I think you should be able to use azithromycin.
Thank you. I'll switch to Dr. Alhuraiji. I mean, there's a question regarding, you mentioned about doing a test for COVID-19. How about, I mean, false negative result and the risk of infection later on with immunosuppressive or myeloablative regimens? Dr. Alhuraiji, you are on the mute.
Sorry, I did not get the question. It was the connection was.
The question is possibility of virus reactivation post-negative test for the patient and the donor. I mean, we might do a PCR. I mean, we might do a test for COVID-19. It is falsely negative.
I think this is possible. We know that the sensitivity of the test is up to 70%, and patients who went into some sort of chemotherapy and before transplantation, the PCR might be less sensitive than those with normal individuals. So I think we have to take it cautiously, but again, there is no solid evidence that we can say what's the percentage of reactivation post-transplant. So I think we have to just take it as negative and then go ahead for transplant and monitor the patient.
Thank you. Thank you, Dr. Alhuraiji. So there's a question from Dr. Bassem Beiruti. Home transplant, BMT at home.
I don't think that we can do it nowadays because of a lot of, we are in a partial curfew in Kuwait, and this is not possible, unfortunately, to do home isolation or home transplant. So I don't think it's possible nowadays.
Okay, thank you so much. I'll switch to Dr. Absi. So there is a question regarding, I mean, should we be more careful about medication that cause lymphopenia rather than neutropenia these days?
Again, yes, yes and no, because there's one thing to contact the disease and develop mild to moderate or asymptomatic infection, and it's another thing to develop the severe hyperinflammatory status. So, you know, if you look at the patient population published from China, cancer patients did have a higher risk, but not only cancer patients, patients with chronic diseases in general. So patients, even they define them as hypertension, diabetes mellitus, cardiovascular disease, and renal disease. All of those patients had a higher risk. So not unique to cancer population at all. So we don't fully understand that mechanism. In my view, and from what has been published, which is the secondary superimposed bacterial infections in the lungs, I think the neutropenic regimens would be of more importance here. I think we want to avoid more severe neutropenia rather than the lymphopenia itself. And that actually goes in line with the AML recommendations that came out yesterday, which is avoiding prolonged neutropenia.
Thank you, Dr. Absi. Another question, 70 years from Dr. Kumar, 70 years old female with AML on AZA and venetoclax. Any special recommendation from you as a precaution for neutropenia?
I'm sorry, what is she on therapy-wise?
So 70 years old female on AZA and venetoclax. And now she's neutropenic. Any special recommendation?
Not really. The question here is really, again, being realistic with these patients and assessing on appropriate manner the response to therapy and assessing the goals of therapy on timely manner rather than leaving the patient and her family in a higher risk situation. But other than the prophylactic antivirals and antibacterials, not much can be recommended here. The AML paper did recommend using venetoclax more often in the high-risk population and the elderly, given the fact that it's associated with less risk of neutropenia and infections. So we already took the lowest risk possible approach in this patient. So I don't think we can go any lower.
Okay, thank you so much. So there is a comment from Dr. Bassem Bayrouti. He's saying that COVID-19 has taught us many lessons, including use chemo-free treatment, less myelosuppressive protocols, maybe to lower the threshold of transfusion. So this is a comment. And I will take the last two questions and we will conclude for Dr. Jain. So Dr. Jain, there's a question from Dr. Khalil Farisi. He's saying that they are still using chlorambucil for older adult patients who are frail. Would you recommend changing this practice with the COVID pandemic? And what regimen are you using or would you recommend for chlorambucil? Is it 7 days or weekly?
So to be very honest with you, we don't use chlorambucil here. We have not used chlorambucil forever, probably here at our center. So, but I do understand. I mean, I think I think that's a discussion, not just for COVID, I think it's a general discussion, but certainly I think ample data out there that for progression-free survival, other therapies, target therapies are better than chlorambucil. So we personally don't use chlorambucil. I don't use chlorambucil at our center. As a group, we have not used it recently or in a long time. So certainly my recommendation would be to do non-chlorambucil based therapy for your patient. But if that's because of the cost issue and some studies have not shown OS benefit, you want to use chlorambucil, I think that's fair. But again, most centers in the world, CLL centers in the world are moving away from chlorambucil. I personally don't think with the COVID issue, you really need to make that big of a change in your practice, but I think that's a general comment about CLL management.
Thank you. So this is the last question. Monthly IVIG for CLL patient. Would you postpone it during COVID pandemic?
So that's, I mean, obviously you're using monthly IVIG for a specific reason. We use it for patients with low IgG level plus frequent severe infections, typically requiring hospitalization. So I mean, I would not hold the IVIG. I mean, I guess the concern there will be that whether going to the medical center to receive the IVIG and the exposure to other patients. I think if that's the argument, yes, that could be entertained to avoid that face-to-face contact in the medical center with other people. But again, in general, we are not recommending stopping IVIG yet. But again, if an individual patient who have not had frequent infections for a long time, they're very stable, they are just getting once a month for the last 2-3 years, do you want to hold it for a few times to again prevent for the social distancing purpose? I think that's fair. I think if you want to do it.
Okay, thank you so much. So by this, we will conclude Society for Blood Disorder webinar. I would like to express my gratitude for all the speakers and panelists, as well as for the attendees for having such an interactive session. We will be sharing with you an evaluation form, will be displayed in a second, as well as by email. I would appreciate if you can fill it out and send it back to us. And thank you all.
Thank you. Bye.
Thank you.
Thank you. Bye.